All right, it looks like our attendees have slowed down for joining, so we're going to go ahead and get started on this Friday afternoon. So hello, everyone. Welcome to the panel on nutrition resilience during international humanitarian crises. My name is Lorna Harp. I'm a master's student at the Friedman School here at Tufts University, and I will be co-moderating along with my fellow classmate, Ayane Ezaki. A few housekeeping items before we begin. First, this session is being recorded for potential publishing on our symposium website, so please modify your name or shut off your video if you do not wish to be recorded. We also ask that all attendees keep their audio off during panel presentations. If you have any questions for our panelists, which we do encourage, please enter them in the chat and we'll raise them at the end of the session in the Q&A portion. So we will start with brief presentations from each of our three panelists, and then we'll have about 30 minutes for questions. We'll do a few moderator-led questions, and then we'll definitely get to your questions from the audience. We'll aim to wrap up around 4:55 p.m. Eastern time, so you can enjoy the rest of your Friday evening and into the weekend. With that out of the way, we'll get into our main event. So this panel was created to talk about nutrition resilience, and the framing for this panel is that in the Somali famine in 2017, it really highlighted the importance of nutrition resilience in populations experiencing humanitarian emergencies. So in this session, we will discuss strategies for identifying, assessing, and responding to nutrition-related issues, as well as outstanding concerns and sort of future research needs for building improved nutrition resilience in the coming decade. And the term nutrition resilience is understood differently by different people, but we really want to focus generally on the concept of supporting communities to maintain adequate nutrition status when faced with a shock like conflict, natural disaster, or a global pandemic. So to speak on these very important topics, we have a fantastic panel of three experts joining us today. Dr. Anastasia Marshak is a senior researcher at the Feinstein International Center, focusing on programmatic impact and causes of malnutrition in Africa's drylands. We also have Dr. Nika Larian, a science and technology policy fellow and food systems advisor in the Center for Nutrition at USAID. And we have Maria Wrabel, a research project coordinator with Action Against Hunger USA, currently leading a study in Ethiopia to improve acute malnutrition treatment. And with that, Anna will start us off by sharing her work on acute malnutrition. Please share your screen when you're ready.
Thank you so much for that great introduction. Let me do a quick check. Can you see my screen? Okay, excellent. So today I'm going to be presenting on some recent research on the seasonality of acute malnutrition in Eastern Chad. And first, a little bit about the context of Chad overall. So Chad suffers from one of the things that we talk about, which is this persistently high levels of acute malnutrition, which surpass the emergency threshold of 15%, basically on a yearly basis. It suffers from disasters such as drought, flooding, locust infestations, conflict both on the east and western side, and is a situation of a protracted humanitarian context. From a more climatic standpoint, the area can be described as drylands with one main rainy season. And then just to give a livelihood context specifically of the area from which this research is presented, it's a mix of pastoralist farmers and agro-pastoralists. So my research really focuses on trying to understand the seasonal patterns of acute malnutrition so we can better put in place programs and appropriate programs at the right time to prevent this protracted, persistent level of global acute malnutrition. So before I talk about my research, I want to talk a little bit about kind of the current understanding around the seasonality of acute malnutrition, specifically in areas that have one main rainy season. And really, there's this perception that we know when acute malnutrition peaks. It peaks during the lean season, the hunger period, which is the same thing as the rainy season, or the pre-harvest period. And that peak is primarily associated with food scarcity before the harvest, as well as incidences of disease such as malaria. So here's a little bit of a visual representation of what that assumption represents. So in this unimodal rainfall context, It's the idea that acute malnutrition peaks right at the end of a rainy season before the harvest. And then as the harvest begins, there's access, prices in markets begin to drop, there's greater access to food, acute malnutrition goes down. As the dry season continues, stocks begin to dwindle, acute malnutrition increases, and in the rainy season, you also have the added burden of malaria. If this pattern looks familiar to you, it's because this is the pattern of basically food insecurity in this context. It is exactly that, where food insecurity increases right before the harvest happens and then decreases as stocks and prices come in. Now, what does that mean? Well, that means that if we're perceiving acute malnutrition to have the same seasonal pattern as food insecurity, that means we have this embedded assumption that food insecurity is the main and primary driver of acute malnutrition. However, doing research across Chad, Sudan, and South Sudan for the past decade, the data wasn't matching up. And so we ended up carrying out a mixed methods longitudinal study with our partner Concern Worldwide. We basically followed 200 children between the ages of 6 and 59 months across 89 households for almost 2 years, collecting data on household and child characteristics, including anthropometry, on a monthly basis. The villages themselves were purposely selected because we wanted to make sure that, since we were doing such frequent data collection, that we could access these communities even in the toughest times during the rainy season. Once those communities were selected, we randomly selected households with children under the age of 5 months in those communities. Besides the quantitative research, we also carried out 2 rounds of qualitative data collection, focus groups, structured interviews, and key informant interviews, both prior to the rainy season and immediately after. So, what did we find? Well, what we found actually was a much more nuanced and complex picture of the seasonality of acute malnutrition. Instead of one peak, as you see in the figure above, which is what most of the assumptions around seasonality exist, we found 2 peaks of varying sizes. We found a primary peak that happened right at the end of a dry season and right before the rainy season. During this period, that's described by local communities as rushash, or scattered rains. It's about a very short 3-week period of when the rains first come after no rains for about 5 months. And then we actually see a decrease in the prevalence of acute malnutrition during the rainy season itself. So as food insecurity is increasing, acute malnutrition is decreasing. And then we see a much smaller secondary peak that occurs right before the harvest. So what does this mean? Well, it means that there are different drivers of acute malnutrition at different times of the year. And that means programming and how we address or prevent acute malnutrition in these contexts needs to be very time specific. We already take this approach when it comes to a lot of our agricultural programs, but not necessarily as much with nutrition. And so the understanding of when those seasonal peaks, and in different contexts that could be maybe 4 peaks, 3 peaks, depending on the rainfall pattern, we see that there are different drivers at different times, and that food insecurity is not necessarily the main driver. A lot of our work in Chad actually points to the fact that primary peak is primarily driven by disease, or zoonotic, particularly zoonotic disease transmitted through water pathways from the migrating herds of cattle and camel that come through that period. So this data that we have, it comes from 8 communities in Eastern Chad. It's a very specific context. So the question is, well, how generalizable is this? And so what we did with Ash Venkat, another PhD student at Friedman, is we took 15 years of smart data, specifically across dryland contexts with only 1 rainy season. And the reason that we felt comfortable aggregating these data sources is because smart data collection usually applies exactly the same methodology for the collection of nutrition data, the 30 by 30 system, 30 clusters, 30 kids per cluster. And so when we aggregated 15 years of this data across the Sahel with about 500,000 of individual observations, we found exactly the same seasonal pattern as we did in our primary data collection. The first peak occurred immediately before the rainy season at the end of a dry season. Then you see this decline in the prevalence of acute malnutrition as food insecurity is increasing, with a much smaller secondary hump that happens at the right before the harvest period. And this was true across all the different livelihood zones, primarily farming livelihood zones, more pastoralist livelihood zones, and mixed livelihood zones. The picture did not change depending on the livelihood. So what does that mean for us? Well, it certainly has implications, as I said, in terms of what programs are put in place, where, and who is targeted. But something that we wanted to look at was kind of maybe doing a different framework about thinking about nutrition seasonality. And we're very lucky because there's a lot of folks at Tufts that actually work on issues of seasonality. We have Professor Elena Naumova, who's been doing this work for decades. We have Ash Venkat, the PhD student, a recent graduate, Ilana Clifford, and we all from our own different angles kind of came to the same conclusion. And so recently we started thinking about and putting together this framework and thinking about nutrition seasonality and nutrition from a much more systems-based approach, rather than that linear model that we're so used to within the UNICEF framework, and thinking about how the different systems interact with each other, affect each other, and how they're different depending on the season, as they all lie within the context of the climatic conditions of that time or place, be it vegetation, rainfall, and temperature. We think that thinking from much more of this systems approach, specifically based within the context of climatic data, this approach can then be applied to other contexts, not just dry lands with one rainy season, to better understand seasonal patterns of acute malnutrition and hence better address it. Thank you very much.
Thanks a lot, Anna. It's really interesting to see how seasonality plays into resiliency and the importance of taking a systems approach to looking at malnutrition, specifically in the drylands of Africa where you were working. Just a reminder to all of our attendees, please put your questions in the chat. We would love to have a great discussion after we hear from everyone, and we will sort of curate those and pass them along. So please don't hesitate to use the chat function. Next, we will hear from Nika Larian, and she'll share her work on the impact of COVID-19 on traditional food markets. So whenever you're ready, Nika.
Thank you for that introduction, Lorna. My name is Nika Larian, and I am a AAAS Fellow in the USAID Center for Nutrition and the Activity Manager for the Feed the Future program Eat Safe, Evidence and Action Towards Safe and Nutritious Food. To begin with a little background, as the US government's Global Hunger and Food Security Initiative, Feed the Future is a cross-agency initiative to sustainably address hunger and poverty. Feed the Future's Deputy Coordinator for Development resides at USAID and drives the interagency process for formulating policies, strategies, and monitoring criteria for Feed the Future. So why are we investing in food safety to improve food security? Because food safety and nutrition are inextricably linked. Unsafe food can cause foodborne illness and diarrhea, contributing to poor nutrient absorption and malnutrition. Moreover, the nutritious foods that we promote, such as animal source foods and fruits and vegetables, are the most susceptible to contamination. Traditional markets are an important source of healthy food in food insecure areas, but they also pose a number of food safety and hygiene risks because they are often crowded with poor water, sanitation, and waste facilities. As you can see from some of these pictures, most of them are from our Eat Safe surveys in Bangladesh. They're very crowded. There's often poor separation between food types, and a lot of the food is displayed on the floor. During COVID, these characteristics understandably make traditional markets a high-risk area for transmission of respiratory disease. Eat Safe is a 5-year multi-country project to enable lasting improvements in the safety of nutritious food in traditional markets by focusing on empowering consumers to demand safe and nutritious food. Eat Safe is implemented by a consortium of partners led by the Global Alliance for Improved Nutrition, or GAIN. As a part of their phase 1 formative research, Eat Safe conducted COVID-19 response surveys to track vendor and consumer perspectives and behaviors relating to nutrition resilience during COVID to inform USAID missions as well as local governments and market stakeholders. From September 2020 to December 2021, Eat Safe conducted surveys and interviews in 2 markets per country in 6 countries: Bangladesh, Nigeria, Kenya, Ethiopia, Tanzania, and Mozambique. Today, we will be focusing on data from a selection of these countries. For time, I'm only able to share a small portion of the results from these surveys. In all countries, consumers' protective behaviors changed during COVID, with changes in shopping behavior increasing over time. Consumers were concerned about contracting COVID, and behavior change prevalence corresponded to the severity of local COVID-19 epidemics. Consumers reduced their time and personal contact in the market. Here we see data from Bangladesh, Ethiopia, Kenya, and Nigeria, demonstrating that consumers avoided peak shopping hours, reduced the frequency of shopping, and reduced the time spent in the market. These changes in behavior tended to increase over time in response to COVID. Let's look closer at some country snapshots to further explore these responses to COVID. In Kenya, 97% of consumers surveyed indicated that they made changes to the food they purchased in the market. Of these changes, 72% of consumers reported decreasing the quantity of food purchased, while 21% of consumers stopped buying some foods. Other consumers increased quantities of certain foods purchased at 14%, or switched from what they usually purchase at 7%. From the nutrition resilience interviews, Eat Safe developed a food price monitoring tool that will be publicly available. The tool will allow users to track food prices over different time ranges, sorting data by country and food type. For example, these data explore the changes in food prices between 2020 and 2021 in Bangladesh to explain why consumers may have changed their purchasing habits over this time. As you can see from these graphs, the prices of pulses and animal source foods increased, most dramatically for fish, while the prices for vegetables such as green papaya and red amaranth decreased over the year. Let's look a little closer at the data for fish prices that we can get from the price monitoring tool. On the top, we can track prices over time to measure price volatility against different events or seasonality. On the bottom left, we can compare prices during a 1-month period from November to December in 2020 in the dotted line and 2021 in the solid line. And finally, on the right, we can look at the yearly change in fish prices, showing that the cost of fish was higher in 2021 than 2020, most notably the 30% increase in fish prices from November 2020 to 2021. In summary, due to concerns over COVID, consumers shopped less frequently and decreased the quantity of foods purchased, likely due to increased prices of certain food items. For example, the increase in fish prices in Bangladesh may have led consumers to reduce their purchasing quantities of this nutrient-dense food. As important sources of healthy food, traditional markets must remain open to promote nutrition resilience for consumers and economic resilience for vendors. Therefore, markets cannot continue to be high COVID contagion zones. As a result of these data, Eat Safe has established technical working groups and engaged local governments and market committees. Subsequently, interventions to improve market infrastructure, including hand washing stations and bathrooms, have been implemented to help keep food markets open, to protect nutrition resilience and food security, even in the face of shocks such as COVID. In conclusion, to promote nutrition resilience, food systems must deliver safe, affordable, and nutritious foods year-round. As the Eat Safe work demonstrates, safe markets are essential for resilient food systems that are able to manage shocks so families aren't left devastated and malnourished after an unexpected disease outbreak, conflict, drought, or flood. So thank you all for your time. I'd like to thank our country offices which conducted this research, as well as the Global Gain Office and the entire consortium that has implemented Eat Safe. I look forward to your questions about the Eat Safe program, and if you have any more broad questions about my AAAS fellowship. Thank you all.
Thank you so much. I think it's a really relevant to see how COVID-19 has sort of modified the discussion around nutrition resilience in these local food markets. So please continue to enter your questions in the chat, and we'll move on to our final panelist, Maria Wrabel. She'll share more with her work on COVID-19 and the management of wasting.
Hi there, everyone. Thanks so much for coming. Let me go ahead and project this. Like Anna, I'm going to check. Can everyone see my screen? Okay, perfect. Let's get started. So today I'm going to be exploring a slightly different facet of the conversation thus far. In a world where communities have strong nutrition resilience, ideally, there would be no need for the management of child wasting or the treatment of acute malnutrition. But unfortunately, we're not quite there yet. And until we get there, it is critical that the organizations and institutions who are supporting communities by providing health and nutrition services also build their own resilience and flexibility to respond in the face of unexpected shocks. So today I'm going to share findings and lessons learned with you from a recent study that Action Against Hunger USA conducted on innovations and adaptations in the management of child wasting during a recent quite dramatic shock that the world has faced, the COVID-19 pandemic. So a bit of background in case there are any non-nutritional technical folks out there. Acute malnutrition is typically treated through a program called the Community-Based Management of Acute Malnutrition. Children are screened within their communities and then come to local clinics to be measured and monitored. Caregivers are provided with special food to give their child at home, and then children come back for follow-up visits until they have achieved a healthier weight and they are discharged. However, when the COVID-19 pandemic hit, we faced a critical challenge in providing these services. How can we continue to provide these life-saving services while reducing the risk of transmitting this virus? Standard protocols require frequent visits to crowded clinics for follow-up visits, close proximity between children and health workers as they take the measurements to assess their progress towards recovery. None of this is ideal during a global pandemic. Therefore, global nutrition coordination bodies released guidance identifying possible adaptations to CMAM programs. These included changes to how children were screened within communities, the measurements that were used to determine their eligibility for enrollment and to track their progress, as well as the dosage of the special foods that were given to them to support their recovery. Many of these changes had been trialed before the pandemic in an effort to improve the effectiveness, cost effectiveness, and coverage of acute malnutrition treatment. But this massive rollout across the globe during the pandemic presented a very unique and critical opportunity to see and learn from these changes in action at a larger scale than ever before. So to capitalize on this unique learning opportunity, Action Against Hunger, in collaboration with UNICEF, USAID, and the US Centers for Disease Control, or the CDC, implemented a mixed method study from 2020 to 2021 to learn from these adaptations. This included a survey to track and map who was doing what and where, a series of interviews with practitioners to identify operational implications of these adaptations on programming in real time, and a secondary data analysis to assess any trends or impact on programmatic outcomes associated with the adaptations that were being implemented, led by the CDC. Here you can see some of the summary statistics of the project. In the interest of time, I'm not going to dive into all of these, but I will just highlight and explain two of the most commonly reported adaptations: family MUAC and a reduced frequency of follow-up visits to clinics, those top two at the top of that chart. So what is family MUAC? MUAC, or your mid-upper arm circumference, is one way that we identify and measure acute malnutrition. You take a color-coded band like this one, you wrap it around a child's upper arm, and if the band reads orange or red, the child is in need of treatment for acute malnutrition. So typically, community health workers are the ones who are responsible for taking these measurements in communities and at clinics. However, the family MUAC approach shifts this to, you guessed it, to the families or to caregivers, providing them with tapes and training on how to take those measurements themselves. The aim during the pandemic is to continue screening when standard community-based methods were suspended during the pandemic, and also to reduce physical contact and enable social distancing between health workers and children. Another adaptation was to have children come less frequently to clinics for follow-up visits. Children with more severe cases typically return to clinics weekly, while children with more moderate cases return biweekly. But during the pandemic, this shifted to biweekly or monthly follow-up visits, depending on the severity of the child's case. And the aim here was to reduce the need for caregivers to travel when movement restrictions were in place and transportation options were limited, and to also minimize crowd sizes at clinics to enable social distancing. And so for those of you who are nutritional technical folks and are interested in learning more about the in-depth findings and lessons learned on these adaptations, I've added a couple of links to my last slide where you can get more information. But for today's discussion about resilience, I want for us to instead focus on a few key takeaways from organizational experiences in responding to the unexpected and unavoidable need to change their standard ways of working. So first of all, it must be said that governments and organizations' uptake of these adaptations demonstrated innovation and flexibility during unprecedented times. And positively, the adaptations were largely successful in achieving their aims. They enabled service continuity while reducing some transmission risks, and in some cases, even streamlined and simplified program management. In addition to building the evidence base on these approaches so that organizations can decide whether or not to continue these adaptations after the pandemic, I believe that this project also demonstrates to us very clearly that we shouldn't necessarily always just default to our default, that what is normal can always be improved and can and should be responsive to crisis. However, in order to enable this innovation, we need flexible funding and strong partnerships. During the pandemic, this enabled the rollout and uptake of these adaptations at a scale we've never seen before. And these institutional and financial allowances for this flexibility can continue to enable this flexibility in the future. The next 2 points are related, so I'll bring them up at the same time. Our study found that we do need more research to optimize these adaptations, more evidence, more documentation of program implications, and importantly, that this sort of documentation and sharing of these lessons learned creates an environment to enable informed, responsive decision-making, even during an unprecedented crisis like the COVID-19 pandemic. We also heard from our interviewees that continuing the adaptations beyond the pandemic, or sometimes even during different phases of the pandemic, would be context-specific. What one organization or one government decided in one context might not work in another. And finally, and most importantly, I've talked a lot about organizational adaptation and flexibility, but it's really not just about us, the NGOs, or the governments leading these programs. To maximize the relevance and impact of these services, caregivers and communities must also have increased ownership over the programs. Aid workers and their programs will come and go, but an effective system is developed by the caregivers and communities participating in it. And it is absolutely vital that these caregivers and communities lead those conversations on institutional change. So here you have a couple more links if you would like more information. You can visit the Action Against Hunger USA website. There's an article published in the ENN Field Exchange, and you can also have a look at the State of Acute Malnutrition website. Just Google COVID-19 CMAM adaptations, and you'll get a bunch of resources. So also happy for anyone to reach out to me directly with any questions. My contact details are below. Thank you so much.
Wonderful. Thanks, Maria. It's really impressive to see how quickly teams could respond to working in the pandemic. And it sounds like they were really able to come up with some valuable lessons learned from that experience. So thank you for sharing. And thank you for all of our panelists for their presentations. We have exactly 30 minutes, so plenty of time for a great discussion. We'll start off with a few moderator questions. We have a few from the audience, but please don't hesitate to continue to use the chat as things come up. Ayane will have the first question for our panelists.
Great, thank you, Lorna. Maybe I'll start off by stepping back a little bit, because you've heard from our three panelists about nutrition resilience from very specific points of view, but I'm curious to ask all our three panelists, that in the past sort of 10 years, there's been an increasing focus on nutrition resilience, or on how communities can be more resilient towards shocks to nutritional status. Of course, this has come sort of in following a wider conversation about resilience in general in the humanitarian sector. I'd love to hear from you three about what your assessment is on the developments that have happened in the past decade around having a greater focus on resilience in nutrition, where you think you've seen real meaningful advances, and where you think some gaps remain. And I think on a related note, sort of what you think might be the priority interventions or areas to focus on moving forward. Maybe we can kind of just go in the order that we had the presentation.
Sure, thanks, Ayane. Super interesting presentations. Very lucky to hear you guys. Well, I think one of the things that we've seen over the past 10 years has been a re-emphasis on wasting as a critical nutrition indicator. It always goes in circles. We focus on stunting, we focus on undernutrition, we focus on wasting and stunting. And there has been this new emphasis on wasting, because what we're seeing is that while there's globally has been incredible progress when it comes to stunting, the decrease stunting has been magnificent, we're not seeing wasting behaving in the same way. And in some contexts, we're actually seeing that the prevalence of wasting has been steadily increasing. If we're talking about places like India, or some of these places where we have these protracted humanitarian crises, that even when we do not have a humanitarian emergency, we're still seeing that the prevalence of wasting is in emergency levels. And that's even when there isn't a drought, when there isn't a conflict. And so there's this understanding that we can't just look at wasting as a humanitarian indicator, but that there's something that is driving this very fast loss of weight. And so there has been this re-emphasis on both understanding wasting across contexts and the prevention of wasting in the past 10 years.
Great, thank you.
Yeah, thank you for this question. I think over the past decade, financing for nutrition has increased, which is great, but we are still lagging behind far what is needed to tackle malnutrition and hunger. Despite this, as Anna mentioned, we have seen improvements over the last decade in reductions in overall stunting, as well as food insecurity. However, COVID-19 has threatened to reverse an entire decade of global nutrition progress and has put millions of children's lives at risk by disrupting all of the systems that people rely on for nutrition, whether that's food, economic, health systems, transportation, everything is connected. Moreover, I think a growing trend that we'll see is as climate shocks such as droughts and floods increase, food systems must be made more resilient, which can be accomplished through a systems approach. I think you'll hear that a lot today. For malnutrition strategies to protect access to safe and nutritious food, particularly for young children and pregnant.
Great, thanks. Nika, you took some of the words out of my mouth. So, so as she just said, I think that over the last decade, there has been a positive increase in a shift towards focusing on this more systems level thinking. So it's not just about providing one-off interventions that can address an immediate need, but instead taking a step back and looking at the bigger picture, like Anna showed us during her presentation. All of these systems work together to either complement or unfortunately undermine each other. And so in order to make significant progress, you would need to address them all holistically. And while there has been some progress in moving towards that, we still have, unfortunately, quite a long way to go. Another point I'd like to make is that over the last decade, we've seen a lot more attention being given to this idea of localization or shifting of power and resources from, high-income country governments to more local communities. And while there's been a lot of conversation around that, if you take a step back and look at the sector as a whole, fundamentally, there still remains the money and the decision-making power in the hands of those high-income countries and governments and organizations to make those kinds of decisions. And so in order to promote long-term sustainability and resilience, a fundamental shift of that power and decision-making towards the communities that are actually engaging in these programs would be, I think, a critical priority.
Great, thank you for that. So my next question is, I think, more directed towards Anna and Nika. I noticed in both of your presentations, obviously more for yours, Anna, we see that there are these there are patterns of seasonality in many, in nutritional status, but also in many sort of associated things like price or access. Knowing that now, thanks to the research that like in this field, what then? How can sort of policymakers, governments, organizations, and other stakeholders in the nutrition world sort of adapt accordingly to recognize these seasonal trends?
Well, I think the first step comes with identifying what those seasonal trends are. If you look at a lot of the existing literature on seasonality, and since this is a data symposium, I'm going to get into the data part of it, that what you find is this categorical definitions of seasons. We say dry versus wet, harvest versus pre-harvest. And the reality, and this is kind of comes with better understanding of perceptions from the community themselves, is that in many contexts, seasons are they're not looked at in such a categorical manner. There's a lot more. If you talk to the communities in some areas, they will list 12 different seasons in the year, because the way that people think about seasons is with respect to their livelihoods. What are they doing at this time of year, given what access to what resources, given market prices? So it's again, thinking about the systems approach that we're all constantly talking about. And it's understanding that seasonality is more than this binary understanding. And this is where we really get into what's great is that we just have so much data as humanitarian actors, because we're always collecting data. And so there has been, this is maybe passé to say, but there has been a data revolution. And so in many ways, we can utilize that existing secondary data to understand seasonal patterns, to understand yearly patterns, to better understand drivers, instead of constantly going back to these same communities and collecting the same data over and over. And just like there's just so much data to work with, there's also a lot more tools that are available to us. There's a lot more models that we can borrow from other fields and apply it now to the nutrition world, things we can borrow from infectious disease. The way that COVID is monitored, when you're analyzing COVID trends, you're not talking about the spring season versus the winter season. You're looking at these daily patterns. And what they found is that then you then have to break it out by region, because these seasonal patterns are not the same across the globe. They're not even the same in the United States. What we thought were like 3-4 different peaks, if you break it out by region, it's actually each region has 2 peaks. And so we have this data at our hands. We have these incredible students that are learning these skills here at places like Friedman. And there's so much we can do with that data to bring our understanding of seasonality forward. And that's probably an important first step. From a programming implications, it's now trying to understand what are those drivers at different times of year, how are they different across different livelihoods, how are they different depending on the market prices that are available, depending on access, depending on COVID, depending on how CMAM is available or treating it. So it's taking all of these pieces together to try to have a more realistic, context-specific, nuanced understanding of seasonality, malnutrition, and its drivers.
Yeah, that was a great response, Anna. Just a couple things to mention, as just to reiterate the context-specific approach. I think that's something that Eat Safe has definitely tried to do. This COVID work is just a small portion of the Eat Safe program. It was actually a pivot away from their initial programming to adapt to the state of COVID, but their goal is working with vendors and consumers in traditional markets and understanding the local context. They've currently launched in Nigeria and they're beginning phase 1 in Ethiopia. The first phase of each is a formative research. So they are in the markets, they are talking to vendors, they are talking to consumers. They're doing focus ethnicity, doing stakeholder reports. They're talking to market committees, they're talking to local governments. They're really trying to understand to then be able to target these interventions, because the goal is to be able to provide safe and nutritious food through these markets, regardless of the time of year, regardless of shocks. And from the particular perspective of Eat Safe, which is focused on food safety, we also want to make sure that in times where perhaps there is reduced quantity of food, the food that is available is of the same quality, because there is a tendency, if there is a that what is available is potentially unsafe, and a situation that we want to eliminate. And so that involves working with the consumers to teach them what to look for, what to ask for when it comes to shopping in the markets, and also talking to vendors to incentivize them to actually pay attention to food safety and make smart decisions for not only their business, but also their consumers.
Great, thank you so much for that. Actually, you touched upon a point that I had noted that I wanted to bring up during the questions, which is this concept of adaptation. Because Maria, your presentation obviously really focused on this, but Nika, the work of Eat Safe is also sort of focusing on an area that's been quite neglected in the world of nutrition. So in light of sort of thinking about nutrition resilience and how institutions and organizations can adapt the way that they work, I'd love to hear more about how what the two of you think are some challenges to adaptations, sort of in changing the way that people work, and sort of bringing in new perspectives. Especially Maria, I'm curious, like if you face any sort of resistance to adapting the protocol. Yeah,
that's a great question. Thank you. So I believe the context in which all of these adaptations took place was quite unique. And I think some of that, having it be in the context of a global pandemic where there really was no choice but to adapt, I think really tore down some of those barriers that organizations would otherwise face. So for example, in a non-COVID pandemic time, if you're trying to implement a different iteration of a nutrition treatment protocol, there would need to be, understandably, discussions with different levels. So the nutrition cluster, the government, the Ministry of Health in a country, to really share what the kind of work that you're doing, ensure that they understand the impetus for those adaptations, and to, when moving away from a standard way of working or a standard protocol, people get nervous because what they've done is what they've done, and it works, and it has been working to an extent. And so there's institutional risk aversion towards implementing some of these adaptations. So when trying to shift away to something new, there's oftentimes a lot of background work that needs to be done to build confidence in these approaches and to build relationships with the stakeholders who are responsible for making these decisions and implementing the programs. During the pandemic, the world was a mess. And so really organizations had no choice but to adapt, because they couldn't continue to do the work the way that they had been doing it, because they had faced so many, there were so many risks involved. And so I think that, the pandemic offered a really unique opportunity to see what would happen if some of those challenges to changing your standard way of working were taken away. But moving forward, if we're going to institutionalize some of these changes or conduct further research on them, we really do need to be mindful of, as I said, institutionalized risk aversion to doing something differently, understanding that like I said in my presentation, what works in one context might not necessarily work in another context. And so building the evidence base in different contexts is really important before just launching to full scale. And also taking the time to really understand why things are the way that they are before we try to change them, and identifying ways to align those motivations with the new ways forward that we are looking to implement.
Thanks. I think that was really well put, and articulating the challenges is really the first step towards moving forward and making these adaptations. We have a couple questions from the audience. I think this is for Nika and Anna, maybe half and half on the question. First, is there any plan to expand Eat Safe to Somalia or maybe other locations that you weren't specifically talking about in your presentation? And similarly, if there have been any studies ongoing, Anna, that maybe you're aware of related to acute malnutrition and food insecurity in Somalia specifically.
So as I mentioned, this was an adaptation, the COVID work as a part of the large Eat Safe project. The COVID work has wrapped up in December 2021, so we are currently no longer doing the COVID work in any of the 6 countries that I mentioned. As far as the Eat Safe program, the 2-phase program, as I mentioned, we have launched in Nigeria. We just wrapped up phase 1, which is the formative research phase. Next, we will be moving into the mission buy-in process in Nigeria, and then actually going into the markets and doing interventions that have been designed specifically for the Nigerian context. Ethiopia, we've just begun phase 1, starting to do mainly some desk reviews in Ethiopia. It's been very difficult to do on the ground work in that country. We are looking for additional countries to launch Eat Safe, but it really just depends on mission interest and their interest in buying into the program.
Anna, anything to add about current or ongoing studies related to acute malnutrition in Somalia?
So we do not have currently any specific studies in Somalia. It is a very difficult context to certainly work in. What we are and currently have is a study in northern Kenya, which has a very similar climatic pattern to southern Somalia. There are 2 main rainy seasons and 2 different dry seasons of different lengths with very different temperature, a hot dry season and a cooler dry season. So a very different climatic environment than what I was describing in Chad. So we're trying to see how much of our learning from Chad would apply to this context, and most likely how different this context is. But I think the key is, as Maria pointed out, is that you have to be context specific. You have to understand what is relevant for this, because the livelihood systems are different, the market access systems are different, the population disbursement is different. And so we're trying to at least expand our understanding to see what is it about our study that's generalizable and what is it about our study that we cannot necessarily apply to other contexts. And northern Kenya is the next place that we're doing this.
Great, thanks. One more for Nika about the metrics of diet costs and whether those costs and affordability could be integrated into the Eat Safe food price monitoring platform. And more specifically, if this total diet cost alongside the cost of staple foods could serve as another sort of early warning indicator in these countries.
Yeah, this is a really great question, and a formal launch. Other great ideas to make this platform more useful that could be integrated team, because I think this is a really great would be a really great addition, as you mentioned, to be a warning indicator.
Yeah, thanks. I thought it was a really good question as well. And I think just enough time for a few more questions. So this is back to the whole group. I really would like to get your thoughts on this. I think there is an imperative to consider women's empowerment when we think about any aspect of nutrition, especially in the global platform at the global level. So how do you think that the goal of nutrition resilience relates to wider goals around the rights of women and girls in humanitarian contexts? Maybe we'll start with Maria.
sorry, wasn't on mute. That is an excellent question. I would love to take a moment to formulate a great response to such a great question. I'm not sure if Nika or Anna has an immediate response.
Yeah, sure. I didn't mean to call you out.
So I think, it's important that we obviously talk about women's empowerment, but I think we also have to talk about the whole community, right? It's not enough for us to tell women, you need to be empowered, you need to know this. We have to make sure we're speaking with the elders, we're speaking with the men, especially in very patriarchal societies where women aren't able to make these decisions without permission from the men. They can't even take the child to the treatment center unless their husband approves of it. So while it's important to focus on women's empowerment, we have to take, I think, a broader community level approach. The other thing I just want to quickly add is that, we talk a lot about gender issues, and it's important to consider gender, but it's also important to consider gender in an evidence-based approach. And if you actually look at nutrition outcomes across the board, boys are much more likely to be stunted, boys are much more likely to be wasted, and boys have a much higher under 5 mortality. And so we need to make sure that we have that evidence, that we're understanding what are the gender differences. And on top of that, I think we also need to go beyond gender. We need to talk about age stratification to make sure that we're addressing nutrition, not just in under 5s, where the entire focus of our field is, but we're looking at the nutrition of the elderly. And in many contexts, like the humanitarian crisis in the Balkans, like some of the humanitarian crisis in South Sudan with the Baragazal famine, you didn't see high levels of malnutrition amongst children. You saw incredibly high levels of malnutrition amongst the elderly and incredibly high mortality rates. But we're not designing or investing in treatment centers or even collecting that data in the first place. So we need to prioritize gender, do it in an evidence way, but also think about disability, age, and certainly an intersectional approach across all 3 of those. Thank you.
Really excellent point. Thank you, Anna. Any other thoughts on this?
Sure, I'll chime in. So obviously USAID is very focused, has focused their nutrition priorities around the first 1,000 days, which includes pregnant and lactating women. And so just because there is a shock doesn't mean that we should lose that focus on women and girls. In fact, we should intensify that focus because in times of shock like COVID, the Eat Safe work has shown that people are buying less food. They may be switching to less nutritious food. They may be reducing the number of meals that they're eating. And given social and gender norms, those women and girls are most likely to experience a reduction in the quality and quantity of the foods that they're able to consume. And so the approach that Eat Safe has taken, which is obviously based in the market, we have learned from our focus ethnographic studies and the other studies that we've done working with vendors and consumers, understanding the gender roles that come into play in each specific country. So for example, in Nigeria, the women don't have a lot of purchasing power, but they do shop in the markets. And one of the differences that we've noticed is that women tend to spend a lot more time in the market. They're more likely to talk with vendors. They're more likely to push back against prices. They're more likely to ask questions. So one of the interventions that we are launching in Nigeria is a food safety stand that we are specifically targeting to women because they're spending more time in the market. They're more likely to ask questions. They're more likely to interact with people in the market. So how can we specifically tailor that food safety messaging to empower consumers, specifically women, to make those decisions to purchase safer food?
Thanks for that point. I think to just add another facet to this conversation around the connection between nutrition resilience and gender empowerment, I think we've seen, especially in some of the adaptations that were made during the pandemic to treatment programs, a lot of those, for example, family MUAC, a lot of the messaging around you should measure your child's MUAC to monitor their nutrition status and bring them to clinics for treatment. A lot of that was directed at mothers, understandably, as primary caregivers. However, in providing mothers with the tools to measure and monitor their children's nutritional status, they're also, the flip side of that is that they may then be blamed or held responsible if their child does end up being acutely malnourished. And then there's this sense of shame or of failure that I wasn't able to prevent my child from getting sick. I'm not going to bring them for treatment. The community will look down on me. My family will look down on me because I didn't take care of my child in the right way. And so to echo what Anna was saying before about ensuring that we take a more holistic view when we talk about gender empowerment, to look at the bigger picture. So if we're targeting messages at women, what implications does that have? If we're focusing on enrolling women in our programs, what implications does that have beyond just increasing the gender diversity or the gender focused language of some of our programs? So just ensuring that we, again, take a step back, look at the bigger picture, and make sure that when we are looking at the relationship between these two issues of gender empowerment and nutritional resilience, that we also keep an eye out for the unintended consequences.
Really great points, and I think inspiring thoughts to end on. So a sincere thank you again to Dr. Marshak, Dr. Larian, and Ms. Wrabel for speaking with us today, and to all of you for joining us on a Friday afternoon. So as a reminder, this recorded session will be posted on the symposium website for later viewing. Enjoy the rest of your evening and have a great weekend.